Hello and welcome everyone to this year's first Decision-Making Voices from the Field seminar, given by the Division of Policy Translation and Leadership Development. My name is Hannah Auerbach and I am a master's student in the Department of Health Policy and Management. I have the pleasure today of welcoming our guest, Dr. Richard Besser, who will be joining Professor Bob Blunden. Dr. Besser, since 2009, has been the Chief Health and Medical Editor at ABC News. He has a BA in economics from Williams College and a medical degree from the University of Pennsylvania. Dr. Besser was formerly at the CDC, starting in 1991 as a member of the Epidemic Intelligence Service, where he worked on the epidemiology of foodborne illnesses. After a stint at the University of California, San Diego, Dr. Besser returned to CDC and rose through the ranks to become the director of the Coordinating Office for Terrorism Preparedness and Emergency Response. In January 2009, Dr. Besser was appointed acting director of CDC, where he coordinated the CDC response to H1N1. For his leadership, he received the Surgeon General's Medallion. Dr. Besser will be telling us about his experiences at CDC during the H1N1 crisis. So please join me in welcoming Dr. Richard Besser.
Thank you. Let me take 1 second, not only in welcoming Rich, but introducing the series. For both the Dean and I, this is very simple. We expect you to be in Rich's role somewhere down the line. We expect you to be in absolutely critical leadership positions. We want you to think about the types of decisions that people that make the world turn and change have to make and what they go through. The whole series is to expose you to the way people facing major choices actually come to that. And unlike many of our seminars where too much of the faculty speak, this is going to be highly interactive between Rich and yourself, with my being only allowed one question after that. With pleasure, we'll turn this over. Rich is going to give you a framework. I'm going to ask one question, then we go to you. You introduce who you are, and we really try to push this as far as we can, understanding lessons for you in the future for making the major decisions. Rich, thank you for joining us.
Thanks very much. It's a real pleasure and honor to be here for this forum and to share my ideas. So my job now, I'm at ABC News. I'm the medical editor there, and so what I do all day is tell stories. And so here, for this forum, I want to try and make my points through stories, and then hopefully lots of questions. I was talking to some students earlier, and I said that as a young child, I always dreamed of being the chief health and medical editor at ABC News, which couldn't be further from the truth. I never imagined that I would be a television doctor. I guess this will play, but I wasn't a big watcher of network news. Now I watch it all the time. So how did I get here? I want to go back to 2009. It was April 22nd, and I was the acting director of CDC. And one of my colleagues, Ann Shookett, who's an infectious disease leader, she said, "Rich, I think you need to come to the flu meeting tomorrow." And we've been having weekly flu meetings for about 3 years. Julie Gerberding started those as a way of us preparing for bird flu. And she said, "I think you need to come. There are these cases of flu, 2 from San Diego associated with pigs. We're concerned that this may be growing, and you should come to the meeting." So I need to back up from there. And how did I get to be the acting director of CDC? January of that year, I was actually with Lenny Marcus in Israel. I was the director of terrorism preparedness for CDC, and we'd gone to Israel to learn from the Israelis. You know, who better to learn from in terms of being prepared for disasters than the Israelis? One of the things I wanted to understand was, why is Israel so ready for disasters and America so unready? Every survey you do, fewer than 5% of people have emergency response kits. So we were in Israel. I have a habit of interesting timing. I think it was an hour before we arrived in Israel, or maybe an hour after we arrived in Israel, the Israelis moved into Gaza. And so they were in crisis mode, and we got to see them during the crisis. But for me, we're in these meetings, they're teaching us a lot. My phone rings, and it's someone from the Obama transition team. And they said, if you were asked to be the director of CDC, what would you say? And I said, I'd say yes. They said, okay, well, don't tell anyone about this. We'll get back to you. So we go back into the meetings, and it was like the next day. I immediately called my wife, right, and told her she couldn't tell anybody. But I go back into the meeting. The next day, I get another call, and it's them again, and they say, well, it's between you and one other person. Are you still interested? And I said, yes. How long would this be for? And they said, well, it would probably be about 6 weeks. Once Obama is inaugurated, we'll name a Secretary of Health. Then we'll put in the permanent director. And I said, that's fine. But during that 6 weeks, you should act like the true director of CDC, make whatever changes you think are required, treat it like the real job. And I said, what's wrong with this? I could learn a lot being the acting director of CDC. To cut this story short, I start reading. I come back. They say, yes, it's going to be you. We're not sure when you're going to be the acting director, but sometime after inauguration. So I got my books out. I start reading some of my favorite leadership books. One is What to Do During Your First 100 Days in Government, and the other was Good to Great, which I really think is a fantastic leadership book. So I'm reading through those. I'm plotting out my 6-week tenure as CDC director, what I'm going to do in the first week and what I'm going to do in the second week, what conversations to hold. Tuesday, Obama's inaugurated. Thursday, I'm in clinic. I'm seeing a teenager. I'm doing a physical. My phone rings. So I leave the room, and it's the personnel office in Washington. And they say, is this Dr. Besser? I say, yes. They said, you're now the acting director of the CDC. And I said, is there someone I can talk to about this? And they said, we'll get back to you. So the next day I go to Washington, and I'd laid out my questions from my book on First 100 Days of Government, and I met with Mark Childress, who was the chief of staff. He was the only political appointee, right? We didn't have secretaries yet. And I said to him, the first question you want to know if you're running an organization is what's the perspective of those above you? And I said, when you look at CDC, do you see it as an organization in need of major change, minor change, or stabilization? And I'm thinking, yeah, minor change. And he said, major change. And I said, why? He said, for too long you've been focused on low probability, high consequence events like pandemics, like disasters. And you haven't focused on those health problems that are causing morbidity and mortality today. Chronic disease, diabetes, cancer. And what I said to him is, why in public health do we have to choose between these two? Why to be prepared for a disaster does it mean that you're not addressing today's issues? And why, if you're addressing today's issues, shouldn't you be prepared for disaster? And he said when it comes to public health, there's a fixed amount of money, and you have to decide how you want to divide that pie. And right now, we feel that the pendulum is in the wrong direction. So move forward back to April, and I go into this meeting to hear about these cases of swine flu. And they tell me about the 2 cases in Southern California, 2 cases now in Texas. They're starting to hear words, and there's this situation going on in Mexico where there are hundreds of people hospitalized with severe pneumonia. The hospitals are overflowing. It's a high morbidity, high mortality disease. They don't know what it is, but they're concerned. And there's samples that have been sent to the U.S. They don't know what's going on here, but it could be flu. So we hear this. I'm sending word up to people in Washington. This is now 4 months into the administration. There's still no Secretary of Health. Daschle had been nominated, and his nomination went down the tubes. And so my 6-week tenure is now stretching into much longer than that, and it's not clear when it's going to end. The next day, we get word that the strain in Mexico is actually the swine-associated strain. And I send word up to Washington. I said, I need to talk. We need to talk. I think the White House needs to know about this. I'm very concerned. And I get an email back saying, we're kind of busy. Could it wait till tomorrow? And I said, no, we need to have this call tonight. So we get the call going, and I'm on, and the head of emergency operations at CDC, and the head of flu, and a few other people. And then from Washington, the assistant secretaries are on, and the newly installed chief of staff is on board. Mark Childress was gone because he was with Daschle. I lay out what's happening with these cases, what we think the situation is. And the chief of staff says to me, on a scale of 1 to 10, how concerned are you? And I just said, that I think this could be the next pandemic. It's a new strain, no population immunity. It seems to be transmitting easily. The situation in Mexico looks like it's highly virulent, very severe. She said, on a scale of 1 to 10, how concerned are you? And I said, an 8. And there's silence on the line. She says, an 8? As if there's really like a pandemic worried scale, right, of 1 to 10. And I said, yes, an 8. I think that this could be the next pandemic, and you have to notify the White House. And that was it. That kind of kicked off our response. So you get off the phone, and Phil Navin, who is this old ex-Army colonel who runs emergency operations, he calls me, he says, an 8? He says, I don't think it's any more than a 6. And I said, well, Phil, I got the response I wanted. And the goal in the communication there was to get this to be taken seriously, and that kicked off our response. As we moved into this response, there were certain principles that we laid out, and they were the basic ones. That we were setting up a unit for surveillance, for clinical guidelines, for all of the aspects, for laboratory science, for all of the aspects that we normally have. Liaison to state health departments, local health departments. We've been exercising for flu for years. We had been doing full-scale exercises for bird flu. Well, unfortunately, it was a different scenario. We had expected that bird flu would originate in a small island, off the coast of Java, and we'd be able to send in a team with antivirals, contain it there, or at least delay its entry into the United States. In the meantime, we could set up surveillance at all the ports of entry in the United States to delay its entry here, so we could get our clinical stuff going and get our antivirals out to everyone who needed them. Well, this strain did not read the plan and was actually detected in the United States, may have originated in the United States. And so while we were off to a good footing because we had done this exercises, we had to adjust. Some of our principles. We would tell people what we knew when we knew it and what we were doing to get new information. We would direct all of our activities towards reducing the morbidity and mortality in this country. And we wouldn't take actions that weren't directed towards that. All of our actions would be based on the best available science, and that they change as we learned more. And that we would be aggressive up front. Because with a new emerging infection, if you're not aggressive up front, you may lose the opportunity for containment. So these were our basic principles. But one other thing that we decided to do that was a little different, and it had to do with our communication strategy. And what we decided was that to ensure we had the trust of the American public, we wanted to make sure that anyone who wanted information got it from us. And we would not turn down a single interview from media. We would have regularly scheduled briefings, and we were going to be transparent in those. And so we went forward from there with our briefings. And once a day or twice a day, I was at the podium, or whoever was relevant was at the podium telling people what we knew and reiterating our principles, telling people that there was a shared responsibility, that there were things we were doing in government, there were things that the public had to do, there were things that individuals had to do. And it worked. It was a very effective way at gaining trust of the public. How do we know it worked? Because this guy was polling the public and was able to tell us it was working. And it was very useful having that information coming back, and it helped reinforce what I think is the proper behavior during a crisis. So we're several days into this crisis, or maybe it was about a week into the crisis, and I'm sitting at home and the phone rings, and it's the White House, and they say, could you hold for the president? And I mean, what I say, yeah, I can hold for the president. So I'm sitting there, and I'm waiting, and I'm hearing in the background, I think there was a Bulls-Celtics game going on. and it didn't sound good for the Bulls. And given that the president's from Chicago, that wasn't a very good situation. So we're waiting. Rahm Emanuel's on there, and you know how he can talk. So we're waiting, and my son comes out of his room, and the president comes on the line, and I said, you know, good evening, Mr. President. I thought my son was going to drop his teeth. It was like, as a parent, it was definitely the highlight. So I explained the situation, and they invite me to come to brief the cabinet later that week. And so I head to Washington on a Friday. I thought the cabinet met like every week or every other day. You know, it's our cabinet meeting. What are we going to do this week? Well, this was only the second meeting of the cabinet, and it was the first meeting of the full cabinet because Secretary Sebelius had just been sworn in. And so I go to do the briefing, and you know, I met with Secretary Sebelius and her people. I said, I'm going to brief the president on this pandemic. You know, can you give me some tips on, you know, how do you brief the president? And we all look around and they say, no, we can't give you any tips. I said, well, how long should the briefing be? They said, well, 7 minutes. So I went in and gave my 7-minute briefing, and the president said, that was a perfect briefing. After that, I heard nothing else he had to say. But then we got to the question and answer period, and Secretary Clinton asked one of the first questions. And she said to me, what's the difference between seasonal flu and a pandemic? And it was a game changer for me when she asked that question. Because what it told me was that elected officials don't know anything. What I mean by that, no, I'm serious, is that they're not elected because they're technical experts in science or in any other area. And if you treat them like they are, it's to our detriment. And so it freed me up to talk to the cabinet like they were any other American who was very concerned about what was going on. And that was really the way I worked at briefing up and briefing political leadership. I wasn't talking to them about R naughts and transmission and how many people are infected per case and you know, epidemic curve shape. It was like, no, here's the difference. Here's why we're worried. Here are things people can do. Here's what, you know, everyone in government can do. Here's what we're asking America to do. And the next day, the president went on the radio and briefed the nation in his radio address with the things I'd said in that meeting. And it was a very effective way to go forward. I want to tell one other story before opening it up to questions. One of the success factors, I think, during the early parts of the pandemic was the fact that we did not have in place an established political leadership. We did not have a Secretary of Health. And so we were able to make decisions very quickly in Atlanta and make changes in guidance posted very quickly. We were nimble. But there can be a downside to that. So we were looking at schools. One of the big issues, children are very important in the transmission of flu, seasonal flu and pandemics. And we knew that children can shed flu virus for about 10 days to 2 weeks. And so we developed a guidance that said, if you're a school, this was very early, this is like in the first 10 days of the pandemic, if you're a school and you have a confirmed case or a suspect case of flu, you should close the school for 2 weeks. All right? Investigate around it, determine what's going on. And we posted this guidance. So I've just briefed the cabinet, and I'm called into Rahm Emanuel's office for a meeting. And in there is the Secretary of Education, Artie Duncan, and Rahm Emanuel, and Secretary Napolitano, and Secretary Sebelius. And Secretary Duncan doesn't look very happy, right? Because we've just posted a guidance to say that schools should close for 2 weeks, and his job is to keep kids in their chairs learning. And one of the downsides of not having a political layer is that we were able to make, in a sense, a policy decision from Atlanta that made sense scientifically, but did not make sense in terms of policy. It had to be weighed with all the other factors. If you're closing a school, where are those kids going to go? What's going to happen to those parents who have to work? Is there a safety net in place that's going to allow them to stay home from work? is the school lunch program revved up to be delivering food to children instead of bringing children in so that they're getting their lunches and their breakfast at school? And there were issues there that went way beyond the science of how long do you shed a pandemic flu strain. So in that meeting in Rahm's office, they made clear a few things. One is that they wanted all of the decisions the government made to be based on the best available science, which for someone from CDC was incredibly refreshing because it wasn't always that way. So I went off to do a briefing with the governors, and they came in with a rewritten policy and said, can you live with this? And what they did was they changed it to schools will close for 1 week, at which time there'll be a reassessment, and that new guidance will come as we have more information. And they said, is this consistent with the science? And I said, yeah, it is. It's a different policy spin, but it's definitely consistent, and that became the policy. And what it taught me was that there are things that technical leaders can do, but in decision making, it's absolutely essential if you're in government that that the role of policy is integrated with that. And I think I'm going to stop there so we can open it up to questions.
So first question is mine. So somebody here calls you 7 years from now, and they just been offered the job of CDC director, and there's some pandemic crisis starting, and they say, Rich, I have a pretty good health background, but there are things I probably should know about this job. If you were going to give them some advice about how they could function in that role in a crisis, what would the things that you would think they wouldn't normally think about that could be very helpful to them?
Yeah. You know, I think that, you know, I was fortunate coming into that job that I'd taken a lot of leadership training, and I had sought out leadership positions for a long time. You know, so when I get that phone call, this isn't going to help them too much. Yeah. But earlier on, I would say challenge yourself, take on leadership positions whenever you can, because the job I took as head of terrorism preparedness emergency response, I took that job 2 hours before Katrina hit New Orleans. So, you know, in terms of, and I didn't know anything about hurricanes, right? But there were people in the organization who did. I mean, so one of the things that I would say is trust your organization. When you're in that leadership position, it's not to be the expert in everything that your organization does. It's to run your organization and allow those who know their job to do that. But the other is, you know, I had been through the National Preparedness Leadership Initiative, and I'm a big believer in the principles of meta leadership. And during this pandemic and pandemic response, I deliberately looked at those and was checking them off to make sure that I was following them. So principle of knowing myself as a leader. I paid attention to that and you know, knew that what I did as a leader, others were going to look at and reflect on. And so there was a period during this, it was about 10 days in, that I announced on Friday, I said, tomorrow I'm taking a day off. I said, it's Saturday, my kid has a soccer game, and I'm going to go watch. And I said to everyone sitting around the table, I said, I expect everyone in this room to take a day off too, and to make sure that everyone on their team takes a day off. And that was an important signal to people, that this is a long thing, that we have to take care of ourselves. And I knew for myself, I was not going to be happy if I was neglecting my family and worried about how they were doing during this crisis. I made sure that the principle of leading across organizations, that I was paying a lot of attention to that. Because if you just focus on CDC and what you're doing in your shop, and you're not thinking about how does that reflect on everyone else who may think that they should be in charge during this. I mean, CDC on paper was not in charge during the pandemic. During a pandemic, Homeland Security is in charge. Well, they don't have health expertise. And as long as we were working together, and I was giving them the authority that was their due, they were very happy to let us take the lead on health issues. There was a press conference. The few days before I went to Washington for the cabinet meeting, there was a press conference at the White House, and they invited me up. And we're meeting in the Situation Room in the West Wing before the press conference. And it's Janet Napolitano, who's the Homeland Security Secretary. There's John Brennan, who's the President's advisor on Homeland Security, and me. And they say, okay, you know, we're talking about how we're going to do this press conference. And it's John Brennan's press conference. He says, "Okay, Janet, any questions about the national response plan? They're going to come to you. Anything around, is this terrorism? Those will come to me. Anything around science will come to the doctor." So we go out onto the stage, right? And I think there was one question that went to Secretary Napolitano. Every other question went to me, and they were able to stand next to me and nod, okay? Which meant that they were on board, and I was able to answer the science, and we were a team. But in fact, Homeland Security was in charge during that situation. And if I had pulled "I'm in charge here" at some point, we would have been squashed, absolutely squashed during that when we were trying to provide information.
All right, it's your turn. Feel free to say, when they call me to be head of CDC, this is what I need to ask you about.
Well, I'm afraid my question isn't about that, but I'm Kathy Tater. I'm a Master's of Public Health student in Epidemiology and Biostatistics here at HSPH. I'm also the school's only veterinary dermatologist as well. So my question relates to the zoonoses aspects of our epidemics. The recent ones, avian, swine flu, they've all had animal health implications. When the earlier epidemics, West Nile virus, showed some of the weaknesses in our public health surveillance system, especially for wildlife and other animals. The response this time to swine flu was different. Could you comment, Dr. Besser, about how the response changed with this epidemic versus some of the other epidemics and pandemics we've had?
How it changed in regards to?
Well, with regards to coordination with other officials, particularly those that are involved in monitoring animal health.
Right. I mean, if you ignore animal health and you're interested in emerging infectious diseases, you're missing the story. Because if you look at where diseases have emerged over the past decades, it's through that animal-human interface. I'm doing a story for ABC News I shot in Cameroon on hunting for the next pandemic, and it looks at the interactions of humans and animals and how you get that crossover event. Well, during this pandemic, we were pretty interested in animal health. And leading up to it, we were as well. There was a lot of work going on around monitoring birds, migratory birds, in looking to see when avian flu would come to the United States. But here with this, there was a lot of work going on with USDA and monitoring the swine and looking at would this virus be an issue there. More to look and see would this strain cross over to animals than were we at risk from them. An interesting aspect of animal health during this had to do with what do you call this pandemic, right? Now I'm talking about a swine flu. If I were still in government, this is the 2009 H1N1 pandemic. It was a bit of a problem that the initial name was swine flu or swine-associated flu because it devastated the pork industry, which, there's no value in devastating an industry. The economy is in trouble. Why devastate an industry if there's truly no risk there? And so there was a big move to try and get us away from calling this swine flu. But as someone was saying during this, once it's called Coke, you can't uncall it Coke. Every cola is Coke. So that was a bit of a problem there on the animal side. I think there needs to be even more work done between those who are involved in animal health and monitoring animal populations and what's done in the human side. And I know CDC is moving bigger into that area.
Next question.
Hi, my name's David Scales. I'm a medical sociologist and postdoc in bioinformatics at Children's Hospital Boston. My question is more kind of on the sociological end. And it's something where you might see yourself, Dr. Besser. And my question is essentially, where are the public health leaders today? that actually speak to the public, because you talk about these situations during the pandemic in which our nation's leaders, literally president, secretaries, were speaking to the public, but that doesn't happen very often. I mean, I think back 30 years ago, the last Surgeon General that I can actually remember the name of is C. Everett Koop.
Right.
That's because it was a public health you could almost say celebrity in a way that spoke to the American public, and the American public listened. I'm in public health, and I can't name a single Surgeon General since, and I don't know who's in that role that speaks to the public. And the reason I want to ask you this is because you're in the luxurious or the unenviable position, your choice, of having sat in both government and in the media, and in kind of both of these roles on both sides of this spectrum. So I'd be interested in your thoughts on kind of where these people that speak to the public are coming from.
Well, that's a great question. I do think that there's a void right now. We're not hearing our leaders talking about health in a way that I think we should. All I seem to be hearing is the word Obamacare thrown around. And I think that the general public doesn't have a sense of what that means in terms of people's health. We're just not hearing that, and I'm not sure why there's that void. As a pediatrician and a parent, I know that now you cannot discriminate against a child who has a pre-existing condition. That didn't exist before healthcare reform, but now that's something that's there. And I know that my kids, when they're 25, they can still be carried on my policy, because the new extension is to age 26. And there's a whole group of young adult Americans who will have coverage that didn't. But that's not being discussed, and I'm not sure why. I took the job at ABC News. It was an interesting period for me. When the permanent director came into CDC, and I'm thinking about, okay, well, what do I want to do next? What's the next kind of challenge? And I looked at a lot of different jobs in academia, jobs in industry, with foundations, but a couple TV networks had reached out to me and said, we liked what we saw on television, would you be interested? And I'm thinking, my initial thought was, no, that's ridiculous. I'm a public health person. But then as I thought about it more, one of the things that went right with the pandemic, especially early, was communication. We were out in front on this, and people trusted what we were saying because we were sharing information. We were trying to practice the principles that we'd learned in a lot of communication courses. And so I thought, well, I could have a podium where I'm talking to, today, I was on Good Morning America today, and I may be on World News Tonight. I could reach 12 or 14 million people today on a health issue. And if I can do that on a regular basis, it may only be 2 minutes. It may only be 45 seconds talking to Diane Sawyer coming out of someone else's piece about listeria and cantaloupes. That's important public health. And I see it as an area where people in public health are not doing enough. I think that oftentimes communication is an afterthought. We write a paper. I did this all the time. We write a paper, it gets picked up, you meet with the media affairs, you tell it, you work on your press release, you work on the statement, and if you get an interview, that's great. Well, if you have a finding in your paper that has to do with risk, and you want the outcome to be that you want to change behavior, well, that takes communication and doing it in a really serious, deliberate way, and a communication strategy, as well as a strategy for implementing a public health program. And so what I'm trying to do at ABC News is practice public health from the front of the camera.
Thank you, Dr. Besser. I'm Sam Vaillancourt, and I can relate to the stories you were saying. I was an emergency medicine resident during the pandemic, and I saw the other side of that story, so that was very interesting. My question is about how to convey uncertainty with regard to research. We come out with those results, and they always come with p-values and uncertainties, and the challenge is, without stepping too much into the policy sphere and keeping some neutral voice from the research side, how do we at the same time convey a strong message to people who may not have much scientific education to start with?
Yeah. Well, let me address that first during the pandemic. Because there we were making decisions and having to make decisions with very limited information. And for people who are in science, you don't want to do that. It's always, well, we've got confidence intervals. So with certain, 95% certainty, we can say this. Well, for the public, that's absolutely useless. And so instead of doing that, instead of bracketing everything we said with, people might consider doing X, Y, and Z, which is kind of standard CDC speak, is one might consider. We would make recommendations. But from the beginning, we said every time we'd get up, I would get up to the podium or someone else, we would say, this is a period of incredible uncertainty. Some things we say today are going to be wrong, and we're going to try and get information out to you right away to correct it. Some things you're going to find on our website will be wrong, and we're going to work to fix that. But based on the best science we have today, here's what we think you should do. And we would explain that, it was always a very challenging thing to balance. One of the questions I'd get early on is, why didn't you close the borders? Why aren't you closing the borders? Look at Mexico. Look at what's going on in there. And you show the footage of everyone with masks and all this. And we've got 2 cases in San Diego. I said, why don't you close the borders? And this is something that there have been tons of modeling data. Even in a best case scenario, it's going to delay entry for maybe 3 weeks. And it's already here. So, trying to explain that to people, I couldn't go through, well, we've done models. And the model says that, if the R naught is this, and the it's like they're all of a sudden, it's like, we've looked at this question, and we're not closing the borders because we know that wouldn't help keep it out. You know why? It's already here. There's an outbreak in New York City, and there's outbreaks over here. And so putting our resources, putting people in to close the borders means we're not going to we can't do something else that will help save lives. That's why we're not closing the borders. So it's being willing to translate science into something in plain English and realizing that at times something you're going to say may be proved wrong by a later study. You have to also have someone covering your back on that too. And as the acting director of CDC, I tried to push decisions down to the appropriate level, and people knew that I had their back. If they made a decision that turned out to be wrong, I wasn't going to, have their head on the chopping block. It's going to be, we'll fix that now. Microphone in front.
I think the former minister of Mexico allows one question.
I'm not a student, but students had the first opportunity. No, I just following up on this question of the balance. Clearly, well, we know that communication is probably as important as the event itself, how it's handled, and there's many cases where communications has been mishandled, and then that creates an even worse crisis than the situation that one is communicating about. And clearly in this case you were masterful in the way you did it, and laying out those principles was great. But the key question is this question of balancing, because balancing between the imperative to protect people but not going beyond to the point where you start hurting economic activity and so forth. In this case, with retrospect, many people said, there was an overreaction. WHO was criticized severely because of that. The Mexican government was criticized. How do you answer that criticism? In terms of the decision-making process, where do you err on which side, knowing that this is a rapidly changing situation where you don't want to inflict collateral damage onto the economy or the relations with your neighbors, while at the same time realizing that if you don't go far enough, you may end up having a major disaster. How does that decision process happen?
That's a tough one, and that's a decision that usually isn't at the level of CDC. That's at a higher level. I argued early on that early in a pandemic or an emerging infection, you have to be aggressive. because that's your only time to potentially contain something or decrease the impact on the population. But there's a point where you have to back away. And it's hard to determine where is that point. As we got more, it was very interesting. So as you get more and more information, you can ease things up to some degree. So I'm in this, we had just agreed with the White House about changing the school closure guidance from 2 weeks to 1 week. And what I said to them is, we're expecting more information. There are teams, WHO teams, CDC teams, PAHO teams in Mexico, working with the Mexican officials, looking at this. And we should know very soon how severe this is in terms of mortality. Once we have that, we feel we're going to be able to back away from some of these guidelines. And so this was a meeting on Friday. Saturday, right, at CDC, we get the word from the teams in Mexico. Turns out there's cases all over Mexico. This isn't, the mortality rate isn't as high as people thought. There's a lot of mild disease all over the country. Really is looking like this is not like a level 5 severity. This is more like a 1 or a 2. And so we call the White House. I'm talking to David Axelrod there and say, I think we can back away from the school closure guidelines. It's not looking so bad. I don't know that we need to, our feeling now is you probably don't need to close schools unless there's a confirmed case. And we're hearing from around the country that school closure is not working. The kids are just going to the mall. Parents aren't staying home. We're not increasing social distancing. And what he said to me was, are you nuts? He said, yesterday you were closing schools for 2 weeks. Today the president was on telling people that we're closing for a week and telling people what they can do to decrease the impact on them. And you want us today to say that, oh, don't worry, you don't have to close schools? He said, no one will believe anything else you have to say. He said, I want more data. And he was perfectly right. You can't take people from here to here in that kind of a time frame and expect that they're going to believe you. And so we started foreshadowing and saying, we expect, we're starting to see good information coming out of Mexico. If this turns out to be less severe, which it's starting to look like, we're going to be able to back away from some of these guidelines. And that was, I got a phone call after one of those saying, a little heavy on the foreshadowing there. But that's what we were doing. And then it was by Tuesday that we were able to move away from the school closure altogether. And it's a really tough decision at the political levels, how you balance those policy sides. One of the things that had been argued for years during the Bush administration is that we needed to have in place the safety net to allow public health mitigation to occur. You needed to have, USDA needed to have the system in place to be able to deliver food to children who were at home. You needed to have, in law, the ability for parents to stay home when they were sick or their children were sick without losing their job, and to get paid. When you have someone who is is eating based on what they're earning that day, they're not going to stay home. That's not and it's a rational decision for them to go to work and leave the child at home. So you need to have that safety net in place to allow public health to do what it wants. But the only time you get any traction for any of that to happen is during the crisis itself. After that, absolutely no way it's going to make it to the political agenda and see movement. So I expect with the next crisis, we're going to be in the same place where we don't have that safety net that allows governments to do what you should do for public health without bearing such a tremendous political cost.
Dr. Besser, Barry Dorn, Harvard School of Public Health. Rich, you mentioned that you heard about this at first when you were in Israel. You met a lot of influential people there and a lot of people who were making very difficult decisions. What were some of the leadership lessons you learned and brought back to do this job as well as you did it?
One of the things that I learned was that there's absolutely no way our country will be prepared for disasters in the way that Israel will. And that's kind of rational. People will prepare for what they experience in their day-to-day life. And the reason Israelis were prepared for terrorism is that there were periods where they were having thousands of of bombs going off. It was part of their day-to-day life, and so you prepare for that. Just as in our households here, most people have Band-Aids because someone's going to fall and skin their knee. It's part of their life that you experience. There are little windows where you can get a few more people prepared, so that whenever there's tornadoes or hurricanes, you can make the message as to you need to get prepared. But you're never really going to get that much traction during that, except if things change. People in this country will prepare for suicide bombers after we start seeing suicide bombers, and hopefully that will not happen. I'm surprised it hasn't so far. It was so fascinating seeing people during crisis in Israel making decisions. There's not one that comes to mind that I'm going to share.
We saw other hands here.
Rosemary Weiber, I'm a Master's Public Health student in Global Health. And I guess for those of us at the start of our career, I know that you had a lot of early experiences that obviously contributed to the positions that you've got now, particularly working in Bangladesh and internationally. I wondered what formative roles or lessons you had early in your career that have stood you in stead over many years now.
Formative things, one is early on I just got really excited about trying to answer questions. The science behind public health. One of my favorite jobs ever was being an epidemic intelligence service officer at CDC and trying to unravel a mystery. I was in the foodborne branch, and my first outbreak was hemolytic uremic syndrome up here in Massachusetts. And I came up here and I spent 2.5 months up here, a lot of it at Boston Children's Hospital. And I was able to link this to unprocessed apple cider from Swansea, Massachusetts. And we found E. coli 0157 as the cause, and it was really, really exciting. I even met my wife there. So I came back, I was the first EIS officer to go out on an outbreak, solve the outbreak, and come back with a spouse. But kind of that curiosity is really key. Wanting to challenge the norm, not taking things at face value. I still get really, the nerd in me goes really wild over analyzing an epi study. This week there was a paper that came out looking at coffee consumption and depression in women. And I really liked digging into that study and getting my read on it, which was very different from the read that was in the press release and was in most of the media outlets. Just unraveling it and trying to understand what it really meant. The other formative thing was some of the stuff in global health. And when I took a year after college and traveled around the world. I bought a round the world ticket and just kept going until I got back before medical school. And I was just exposed to a lot of health problems around the globe, a lot of issues of social justice, and that's been very important to me throughout my career as well. I knew that I wanted to do work in global health. Because of life circumstances, being based globally is not what my career's turned into. But throughout, even now at ABC, we're fortunate to have funding from Bill and Melinda Gates Foundation for our global health coverage. So tomorrow night on World News, I have a story about the introduction of pneumococcal vaccine in Kenya and the issue of the global burden of pneumonia. Well, I mean, how cool is that? Network TV covering a problem that's that's really big in Africa and is not so big in Topeka. That's for me really, really exciting.
Good morning, Martin Reedy. I'm a master's student in the Department of Society, Human Development, and Health. And just one question. You mentioned briefly you had thought about academia as a possible pursuit. If you just had your schedule freed up, hypothetically speaking, you had the opportunity to be invited back here to teach a course, and they said, we want you to teach our students about leadership. what are some of the things you'd want to put into that course, whether it's the type of objectives you'd set, or even bringing in other speakers or possibly cases you'd like to look at?
This is a serious question because we're going to ask them.
Well, I mean, I mean, I love to teach, and have with every job I've had, I've tried to do teaching. I love teaching outbreak investigations. But you've got such great leadership stuff available here. I'm on the advisory board for NPLI. I'm a big, that model really speaks to me. The model of meta leadership and looking at dimensions and breaking leadership down into components. Someone was asking me, are leaders born or are they made? And it's both. Everyone has certain traits that that will impact on what kind of leader that they're going to be, but everyone can improve by learning, and that's really exciting. When you see somebody, when I first heard about Giuliani during 9/11 and his communication, I was just blown away by how well he communicated. And someone said to me, well, do you realize that he had practiced all of those messages for years? That at his staff meetings, they would rehearse those messages? I said, do you think more or less of him as a leader for that? And my initial thought was, geez, I feel like I was conned. But then in reflection, it's like, no, that was perfect. He understood what was the most devastating scenario that could hit New York, and he worked on what he would communicate during that. And he did it beautifully. And I think that's a principle of leadership, is you look at what are the risks, you exercise, you practice, you do that. Case studies are invaluable, especially if you can talk to people who were involved during that event. Of how did you decide to do that? Well, I mean, getting at that, and these forums I think are a great way to do that, can really help you understand that. So now you've got great resources here and people to learn from in terms of leadership, crisis leadership, and leadership outside of a crisis, where things are a little different.
Let me, one more question. We all take instructions from the back. Who's our one more question? There we go.
My name's Audrey Shannon. I'm in the master's program for health policy and management. And as you've crossed over into the media, as we know, media really likes to cover the stories that they find the public will be interested in. So H1N1 is a very, exciting issue to talk about and other things. But in health policy and management, we really deal with the less desirable topics, childhood obesity, diabetes, even health reform. How do you manage that role at ABC News and, manage your own interest in those topics and maybe some resistance on covering them on a national scale?
Yeah. It's a real challenge, and it runs exactly opposite to what public health does, right? People in public health are anecdotes, right? They're not data. It's just a person and their story. And in public health, in epidemiology, you want to make sure that you're not swayed by that individual. It may help you generate a hypothesis, but then you use data to look at the problem and come up with risk factors and such. In television, it's the exact opposite. You have to take a problem like childhood obesity or diabetes and find a character to illustrate that. And it's really challenging, and I'll often get pitched stories from, we have a study coming out, it's showing that, such and such have a twofold increase of Alzheimer's disease or of diabetes. Do you want to interview the researcher? And it's like, no, but can you help us find a character to illustrate that? And that's what you need to think about when you're thinking about how do you use media to promote public health. It's taking it from the this, which is where you operate in public health, and drilling it down to the individual. So my story on pneumococcal vaccine for Kenya isn't about 1.5 million children die each year around the globe from pneumococcal disease. The current vaccine has 10 serotypes, which account for 87% of pneumococcal disease. Introduction it's like everyone's out. So the story is about a mother in Kibera, the largest slum that's there, and how one of her children had pneumonia and almost died, and she has a baby that we're going to go vaccinate. And that puts a face on it. And the mother's hope that her next child will not have pneumonia. And that tells the story. And that for $3.50, that's all it takes to potentially save this child's life. And that's really fun, is seeing how do you tell important public health stories to a national audience, often in 1 minute and 20 seconds.
So in closing this, our personal story, in the course of H1N1, we of course were watching Rich on television, and this universal thing, just, we've never seen anybody communicate like this. This is just incredible. For this, there has to be another role for him, because he could explain this to people, to officials, and it was awesome. And we won't say this, but he couldn't make every briefing. So we had a controlled study. Not everybody who did the briefing when he was there had exactly the same skill. And it was incredible. If he was there, you could understand it. And people in the Congress and newspaper reporters, and that skill was so powerful because it reassured people of where you were going. So it has been just awesome to sort of watch the move from one role to the other. But also, for those of you who don't follow the commentators, when he took the job, he insisted that it be a public health role explaining public health issues, not just the latest clinical finding about how one organ system was treated or another. And he is playing an incredible role in educating millions of people to raise a level. So we are just grateful that he spent part of the day with us, also that he advises Lenny Marcus in an incredible program. But thanks again for everybody, Rich. And thanks for doing what you're doing. Thank you.